Welcome to the Deep Dive. You've got something you need to really understand, maybe for exams or just to get a solid grip on a topic. Send it our way. We take that info, boil it down, and help you lock in those crucial insights. Think of it like getting the high-yield knowledge ready to use.
Exactly. And today we're tackling vitamin B12 deficiency based on some pretty comprehensive revision notes a listener sent in.
Right, B12. You hear about it, but its impact is, well, quite profound, isn't it? Affects blood, nerves, overall well-being. We're going to break it all down today, some surprising facts, I think, and clear explanations.
Yeah, the goal is to cover everything from the absolute basics like the definition right through to the causes, symptoms, diagnosis, management, and potential complications. By the end, you should have a really solid handle on B12 deficiency.
Okay, perfect. Let's dive right in then. In simple terms, what exactly is vitamin B12 deficiency?
Fundamentally, it's having low levels of vitamin B12 in your body. And this isn't trivial because it causes problems. It particularly affects the production of healthy red blood cells, the function of your nerves, and even how your body makes DNA.
Okay, so key consequences.
The two big ones are megaloblastic anemia, where red blood cells become abnormally large and don't function properly, and various neurological issues.
So B12 is pretty crucial then.
Oh, absolutely vital. Essential for healthy blood, a functioning nervous system, and, like I said, DNA synthesis. You need it for building new cells. Absorption is key, too. It mainly happens right at the end of the small intestine, the terminal ileum.
And it needs help to get absorbed, right? Something called intrinsic factor.
Precisely. Intrinsic factor, or IFF, is a protein made in the stomach that binds to B12 and allows it to be absorbed in the ileum. There's a tiny bit of passive absorption, too, but IF is the main route.
Where do we actually get B12 from?
Mostly from meat and other animal proteins. That's a really important point when we talk about causes later on. Interestingly, our body stores quite a bit, usually enough for 2, maybe even 4 years, around 2 to 3 milligrams.
You mentioned pernicious anemia earlier. How does that fit in?
Right, pernicious anemia, or PA, is a specific cause. It's an autoimmune condition where the body attacks stomach cells. This leads to autoimmune gastritis, a lack of stomach acid, that's eclohydria, and critically, a deficiency in that intrinsic factor we just talked about. No IF means poor B12 absorption.
Okay, that lays a good foundation. So a quick memory tip I saw was linking B12 to blood and brain too.
That's a great mnemonic. Yeah, it really highlights its dual role in blood health and neurological function. Very good. Shall we move on to why someone might become deficient? The etiology.
Yes, let's do that. What are the main culprits behind low B12 levels?
Okay, several key reasons. We've just covered pernicious anemia, the autoimmune attack stopping IF production. That's a big one. Then there are dietary issues. This is particularly relevant for vegans and sometimes vegetarians if they're not supplementing adequately, because B12 is mainly in animal foods.
So it's not just what you eat, but also if your body can actually absorb it.
Exactly. Malabsorption is another major category. Conditions affecting the small intestine, like celiac disease or Crohn's disease, can impair B12 uptake. Also, gastrointestinal surgery, like having part of the stomach removed to gastrectomy, can really impact absorption pathways.
Are there any common medications that interfere?
Yes, definitely. Certain drugs are known culprits. Long-term use of proton pump inhibitors, or PPIs, used for acid reflux, and metformin, a common diabetes drug, can both reduce B12 absorption over time. And finally, there are some rarer genetic disorders that affect B12 metabolism.
The notes also mention distinguishing this from other causes of megaloblastic anemia. How important is that?
Very important. Folate deficiency is the other main cause of megaloblastic anemia.
Yep.
It can stem from poor diet, certain diseases, or drugs. But crucially, folate deficiency alone doesn't usually cause the neurological problems seen in B12 deficiency. That's a key differentiator. Also, just having large red cells macropsychosis isn't always B12 or folate, like pregnancy, alcohol excess, liver disease, hypothyroidism, certain blood disorders, other drugs. Lots of possibilities.
Okay, practical point then. A long-term vegan comes in feeling fatigued. B12 deficiency is definitely something you'd consider high up on the list.
Absolutely. The classic scenario where dietary intake is the likely primary issue. You definitely want to investigate B12 levels.
Right. So building on the causes, let's talk risk factors. Who is actually more likely to develop this?
Several groups are at higher risk. Advanced age is one factor. Absorption efficiency can decline as we get older. We've touched on gastrointestinal disorders already, celiac, Crohn's, those are significant risks. Gastric bypass surgery, again, dramatically changes the digestive system and increases risk. And of course, having diagnosed pernicious anemia itself.
And lifestyle factors, diet, medications.
Yep. As we said, strict vegetarian or particularly vegan diets without careful supplementation. Long-term use of those specific medications, PPIs and metformin, is another key risk factor. And finally, a family history of pernicious anemia, or those rarer genetic B12 metabolism disorders, puts individuals at higher risk too.
That's quite a list. Is there an easy way to remember those? I saw Mnemonic mention AVG-PGL.
Yeah, that works well. Let's refine it slightly like you did. Advanced age, vegan diet, gastric issues, Crohn's, surgery, etc. Pernicious anemia, long-term meds, PPIs, metformin, and add F for family history. So AVG-PGLF.
AVG-PGLF. Got it.
Yeah.
Helps structure the thinking. Okay, let's get into how the pathophysiology, what's actually going wrong inside the body.
Okay, so it starts with intake, getting B12, usually from animal foods. Then in the small intestine, it needs that intrinsic factor to be absorbed into the bloodstream. Deficiency arises either because you're not taking enough in or, more commonly, because something's impairing that absorption process.
And once those levels drop, what are the downstream effects?
Well, it disrupts fundamental processes.
Mm.
B12 is crucial for DNA synthesis, so a lack impairs cell division. You see this clearly in the bone marrow, leading to those large, dysfunctional red blood cells, the megaloblastic anemia. But it's not just blood cells.
The nerves, too, right?
Exactly. B12 is vital for maintaining the myelin sheath, the protective coating around nerve fibers. Deficiency messes with myelin formation and maintenance, which disrupts nerve signals. That's where the neurological damage comes from. It also affects metabolic processes within the nervous system itself.
So it's almost like B12 is a key building block or, I don't know, a vital lubricant for cell production and nerve function. Take it away, and things start to grind and malfunction.
That's a great analogy. Yeah, it's a critical component. Without it, cellular machinery and nerve wiring start developing serious faults.
Makes sense. Now, differential diagnosis. When someone has symptoms that could be B12 deficiency, what else needs to be on the radar?
The big one, as we mentioned, is differentiating it from other causes of megaloblastic anemia, primarily folate deficiency. Also, certain medications like methotrexate can cause similar blood picture changes, and sometimes bone marrow disorders need ruling out. It's really crucial because the treatment differs significantly. Giving folate alone when B12 is deficient can be harmful neurologically.
And what about the neurological symptoms, the tingling balance problem?
Yes, those can overlap with other neurological conditions, things like multiple sclerosis or various kinds of peripheral neuropathy from other causes. So you need a thorough workup to really pinpoint B12 deficiency as the cause, especially when neurological features are present.
Okay. How common actually is this? What's the epidemiology look like, particularly in the UK?
We don't have one single precise prevalence figure for the whole UK population, but we know it's reasonably common. It's definitely more prevalent in older adults, also in vegetarians, vegans, and people with those GI disorders. For pernicious anemia specifically, the prevalence is maybe around 1 in 1,000 people in the UK. The incidence, so new cases per year, is roughly 1 to 5 per 100,000.
And B12 deficiency more broadly, not just PA.
The prevalence really climbs with age. It's estimated around 6% in people under 60, but jumps up to maybe 20%, 1 in 5 in those over 60. And the estimate for vegans is around 11% potentially being deficient, which is quite significant.
Wow, that jump in the over 60s is striking.
It is. And for PA, the typical age of diagnosis is between 40 and 70, average onset around 60 for white individuals, maybe closer to 50 for black individuals. There's also a mention of a bimodal pattern in young black females, meaning it can occur in younger age groups too.
Interesting variation. So knowing who's at risk, what are the actual symptoms? What's the clinical presentation like?
It can be really varied. Common things are fatigue, just feeling generally weak, maybe getting short of breath easily, pale skin. Some people get a sore, red, inflamed tongue that's called glossitis. But often the neurological symptoms are what cause most concern. Tingling, pins and needles, numbness, especially in hands and feet.
Difficulty walking, memory issues.
Yes, exactly. Difficulty with balance, walking, memory problems, even confusion. And psychiatric symptoms can occur too: depression, irritability, mood changes. In more severe cases, the megaloblastic anemia is usually apparent on blood tests.
Are there other signs a clinician might pick up on examination?
Yeah, potentially. Besides the pallor or maybe slight jaundice from red cell breakdown, you might find signs related to the anemia itself, like a fast heart rate. Neurologically, you test sensation vibration sense and proprioception joint position sense are often affected early because the dorsal columns of the spinal cord are involved. You might find abnormal reflexes like brisk reflexes or upgoing plantars, Babinski's sign, muscle weakness or increased tone, spasticity. Ataxia, poor coordination can develop later.
Any other less common features?
Rarely, you might get changes in vision, specifically a yellow-blue color blindness. The psychiatric features can become very prominent in advanced deficiency. Severe anemia can strain the heart, potentially leading to heart failure, particularly if there's an added stress like an infection. And sometimes the liver and spleen might be slightly enlarged, hepatosplenomegaly.
Okay, that's a very broad range of potential signs and symptoms. Another mnemonic was mentioned for the key features, 5Ps and neuropsychich.
That's the one. Fatigue, pallor, pale skin, paresthesia, tingling, numbness, peripheral neuropathy, and psychiatric symptoms. Covers a lot of the common ground. And you can throw in glossitis for the sore tongue, too.
Great, helps to cluster them. Now, investigations. If B12 deficiency is suspected, how is it confirmed?
Right, diagnosis. It's important to know there isn't a single gold standard test. And crucially, the standard serum B12 level can sometimes be misleading. It can be in the normal range, even when a functional deficiency exists at the cellular level.
So what else do you look at?
We often need additional tests to assess the functional status. Measuring plasma homocysteine and methylmalonic acid, MMA, are key here. Levels of these tend to rise when B12 isn't doing its job properly. Allotranscobalamin, which measures the active B12 bound to its transport protein, is another useful test, though maybe less widely available. And remember, reference ranges for B12 can vary a bit between labs.
What about basic blood tests like the FBC?
The full blood count and blood film are vital. You look for that macrocytosis, the increased MCV, meaning large red cells. You also look for hypersegmented neutrophils on the blood film. These are white blood cells with more segments in their nucleus than usual. Seeing these strongly suggests B12 or folate deficiency. But in early deficiency, the FBC and film might still look normal.
Any other biochemistry tests that help?
Yes, you might see a slightly raised unconjugated bilirubin level due to ineffective red blood cell production and breakdown in the marrow. Checking liver function tests, LFTs, thyroid function tests, TFTs, and maybe protein electrophoresis helps rule out other causes of the symptoms or macrocytosis. Serum vitamin B12 is usually the first specific test done. A level consistently below, say, 200 NGL is generally considered indicative of deficiency, but there's a gray area. As mentioned, elevated homocysteine and MMA are more sensitive indicators of metabolic deficiency. And you absolutely must check folic acid levels too, as deficiency can coexist and needs managing carefully.
Okay, and what about tests to figure out the cause? If you know someone's deficient, how do you find out why?
That involves looking for the etiology. An autoantibody screen is important, looking for antibodies against intrinsic factor, IFAB, or gastric parietal cells. IFAB are very specific for pernicious anemia, though not everyone with PA has them. Parietal cell antibodies are less specific, but often present in PA. We used to do the Schelling test to assess absorption, but that's largely unavailable now. In unclear cases, a bone marrow aspirate might be needed, though less common now with better blood tests. Finding reduced stomach acid, enclohydria, or absent IF in gastric juice points strongly to PA. And importantly, a gastroscopy might be needed for people with PA, especially if they also have iron deficiency or other GI symptoms, because of that slightly increased risk of gastric cancer.
So it really sounds like a combination of clinical suspicion, initial tests, and then often more specific tests, sometimes including autoantibodies or functional markers, to build the full picture.
Exactly. You need to integrate the clinical findings with the lab results. And the big take-home is, don't rely only on the serum B12 level, especially if it's borderline or doesn't fit the clinical picture. Consider MMA and homocysteine.
Right. Makes sense. So once the diagnosis is made, how is B12 deficiency typically managed in the UK?
The cornerstone of management is replacing the deficient vitamin B12. This is usually done with supplementation. Depending on the cause and severity, this could be oral B12 tablets or, more commonly, intramuscular injections of hydroxycobalamin. For conditions like pernicious anemia or irreversible malabsorption, these injections are usually lifelong.
What else is involved?
Addressing the underlying cause is crucial, if possible. So dietary advice and supplementation for vegans, treatment for Crohn's or celiac disease, reviewing causative medications, etc. And regular monitoring is key, checking B12 levels periodically, assessing the clinical response, making sure the anemia resolves and neurological symptoms improve or stabilize.
Can you give specifics on the injection schedules?
Sure. If there's no neurological involvement, the standard UK approach often starts with intensive loading doses. For example, hydroxycobalamin 1 mg injected intramuscularly 3 times a week for 2 weeks. After the loading phase, maintenance therapy is usually 1 mg every 3 months. If neurological symptoms are present, the initial treatment is often more intensive, maybe injections every other day until symptoms stop improving, followed by the 3-monthly maintenance.
And that point about coexisting folate deficiency?
Yes, absolutely critical reminder. If both B12 and folate are deficient, you must treat the B12 deficiency first, or at least start treatment concurrently. Giving folate alone can precipitate or worsen neurological damage in B12 deficient individuals. It's called subacute combined degeneration of the cord.
Okay. When should someone be referred to a specialist?
Urgent referral to hematology is needed if there are neurological symptoms or if deficiency is found during pregnancy. Routine hematology referral is wise if the cause isn't clear after initial tests or if there's any suspicion of an underlying hematological malignancy. Gastroenterology referral is indicated if malabsorption, other than typical PA, is suspected, or for patients with PA who have concerning GI symptoms or need screening for gastric cancer. And referral to a dietitian makes sense if the deficiency is clearly diet-related.
What about those borderline cases? Low serum B12 but no clear symptoms or anemia subclinical deficiency?
That's a common dilemma, especially in the elderly with non-specific symptoms like fatigue. Management often involves clinical judgment. Using those second-line tests MMA, holotranscobalamin can be very helpful here to clarify if there's a true functional deficiency. Sometimes, just repeating the serum B12 after a month or two is reasonable. If clinical suspicion remains high despite borderline tests, a therapeutic trial of B12 might be considered. A positive IFAB test usually confirms PA and warrants lifelong treatment. If IFAB is negative, MMA holotranscobalamin results can guide the decision. If those functional markers are normal despite lowish serum B12, treatment might not be needed.
So very much tailored to the individual patient, their results, and their symptoms.
Precisely. Not a one-size-fits-all approach. And always remember that B12 first rule if folate is also low.
Got it. So assuming treatment is started appropriately, what's the general prognosis?
Generally, the prognosis is very good with treatment. B12 supplementation effectively corrects the deficiency, reverses the anemia, and usually improves most symptoms. The main caveat is neurological damage. How much that recovers depends on how severe it was and how long it was present before treatment started. Some neurological deficits might be permanent if treatment is delayed, so prompt diagnosis and treatment are key for the best outcome, along with ongoing management to prevent recurrence, especially if the underlying cause persists.
That's mostly positive then, especially with timely intervention. But what if it's not caught or treatment isn't consistent? What are the potential complications?
Untreated or prolonged deficiency can lead to serious problems. The megaloblastic anemia itself can become severe, causing significant fatigue, weakness, even heart problems. The neurological damage is a major concern. Peripheral neuropathy, problems with balance and coordination, cognitive impairment, memory loss, potentially becoming irreversible. There's also some suggestion of an increased risk of cardiovascular disease, possibly related to elevated homocysteine levels.
Anything else?
Yes, in pregnancy, deficiency increases the risk of neural tube defects and other developmental issues in the baby. The bone marrow's ability to produce all blood cells effectively can be impaired. Sterility or infertility can occur in both men and women, though this is often reversible with treatment. And as mentioned, that slightly increased long-term risk of gastric cancer, specifically in people with pernicious anemia.
Okay, so quite a list of potentially severe consequences really underscores why recognizing and managing B12 deficiency is so important.
Absolutely. Avoiding these complications is the primary goal of timely diagnosis and consistent treatment.
All right, let's quickly recap. Vitamin B12 deficiency, low levels impacting blood, nerves, DNA. Causes range from autoimmune pernicious anemia to diet, especially veganism, to gut absorption issues or medications. Risk factors include age, GI conditions, certain diets, meds, and family history. Symptoms are broad fatigue, pallor, glossitis, but critically, neurological issues like tingling, numbness, balanced memory problems, and psychiatric changes.
Diagnosis isn't always straightforward. Serum B12 can be normal. Need to consider functional tests like MMA, homocysteine. Look for macrocytic anemia, hyperpigmented neutrophils. Investigating the cause often involves autoantibodies. Management is B12 replacement, usually injections for PA or neurological symptoms, often lifelong. Treat B12 before folate if both are low. Prognosis is good if caught early, but untreated leads to complications like irreversible nerve damage, severe anemia, and others.
Perfect summary. We've really broken down those revision notes, hopefully providing a clear, high-yield overview for anyone needing to get a handle on B12 deficiency. We hope the Mnemonics AVG-PGLF and the 5 EPs help make it stick.
Yes, the aim was clear, concise, and memorable information based on that source material.
Now, a final thought to leave you with. Given how prevalent B12 deficiency seems to be, especially in older adults and maybe vegans, what are the bigger public health implications we should be thinking about?
That's a really interesting point. It raises questions about potential screening programs in high-risk groups, fortification of foods, clear public health messaging about dietary sources, and supplementation needs. Lots to consider there.
Definitely food for thought. For more revision resources, especially if you're prepping for the MSRA, do check out pastthemsra.com.
And freemsra.com also has excellent free materials.
Great stuff. Thanks for joining us on this deep dive into vitamin B12 deficiency.
Pleasure. Until next time.